So today we're trying to cover one of the most difficult controversial topics because data is changing and it's a little tricky. But okay, rectal cancers. Okay, to understand rectal cancers, we need to talk about these clinical landmarks. One is the anus anorectal junction. Okay, and anus is where the anal sphincter is. Okay, then the dentate line, we already spoke about, it's in between the anal canal. Anal bulge is where the skin is external. Now, why it's important? It's important is because neoadjuvant treatment or a rectal based protocol should be considered for tumors which are less than 12 centimeters from the anal bulge. If it's more than 12 centimeters, then just manage it like a colon cancer, not like a rectal cancer. So there will be no neoadjuvant treatment. Okay, but in a rectal cancer, it's heavily reliant on neoadjuvant treatment. Why are we talking about neoadjuvant? Because we are talking about sphincter preservation. We want to preserve the anal sphincter, and that is possible when these tumors are greater than 5 centimeters from the anal canal. Anal bulge. Okay, sphincter, 5 centimeters distance. 5 centimeters distance is needed to preserve the sphincter. MRI is important. Now, rectal cancers are divided into low, less than 5 centimeters from the sphincter, mid 5 to 10 centimeters, and high rectal is greater than 10 centimeters from the sphincter. Now, the thing is that closer to the sphincter, the harder it is to preserve the sphincter, obviously. So, closer to the sphincter may need abdominoperineal resection as compared to the other types of surgeries, which we'll discuss in just a minute. Okay. Neoadjuvant treatments are indicated in tumors which are greater than, less than 12 centimeters from the sphincter. Radiation and endoscopic and staging processes to be done. So you can see over here. So now we're talking about the surgery types to remove the tumor. Okay. Now here you have the LAR, low anterior resection. Okay, here is you come really low and you try to preserve the sphincter, save the sphincter, and you do an anterior resection. Ultra low is you come extremely close to the sphincter. We leave this to the surgeon to decide. And abdominoperineal resection is with the permanent stoma when it's less than 5 centimeters from the sphincter. This used to be done for anal canal, but now we don't do it anymore because the stoma is very burdensome. Okay, now if we are talking about which surgery to do, obviously if it's a high rectal tumor, in that case we would do a low anterior resection. If it is a mid-rectal tumor, like between 5 and 10 centimeters from the sphincter, we could consider an ultra-low anterior resection. If it is less than 5 centimeters from the sphincter, you cannot dissolve the sphincter. You need to do an abdominoperineal dissection. Now, here the anatomy is very important because you can see here this is the rectum, okay, and you can see the peritoneal lining. So all colorectal cancers have staging from T1 to T4 based on the penetration into the mucosa. So T1 penetrates through the mucosa, T2 through the muscularis mucosa, T3 is through the muscularis mucosa, and T4 is penetrates through. Now the importance in staging here is T2 is through the muscularis mucosa. T3, you measure the distance penetrated through the muscularis mucosa and put it in ABC. And T4, it goes through. Now, these organs are hanging in the peritoneum or the mesorectum. Okay. So, T3, we know it goes through the muscularis propria over here. And T3A, T3B, T3C is if it's less than 1 millimeter through the muscularis propria, it would be low risk. If it's 1 to 5 millimeters beyond the muscularis propria, it would be intermediate and greater than 5 to 15 mm. And T4 is that when it penetrates through the muscularis propria, and T4 would go through the peritoneal reflection. Okay, so now we need to understand that these rectal cancers are hanging in the peritoneum, and you have the anterior peritoneal resection here, and you have the posterior peritoneal resection here. And because this is hanging in the peritoneum, all the skin and subcutaneous tissue which is outside the peritoneum ends here. So here you have some fascia over here, which is called the mesorectal fascia. And this mesorectal fascia has all the lymphatics and blood vessels. So to manage a rectal cancer, it would be impossible to leave this mesorectal fascia because there will be residual cancer cells. So it is always indicated to do a mesorectal fascia removal and the staging, lymph node staging. Now T1 we could do surgery only in the higher rectal cancers. With T2, T3, T4 you need to do mesorectal fascia removal also. So you want to downsize the tumor to try and decrease the morbidity of the procedure and save the anal sphincter. Okay. Now here rectal cancer's treatment has changed dramatically because of the stoma inconvenience. So there was a Swedish, Dutch, German, Korean trial, Opera, Rapido, Prodigy, and Prospect trials, each of which have been done. We'll try to cover it very briefly because can't have a very long video. So this paper by Arthur Affleck et al. Has nice collection of information, and here you can see total mesorectal origin was established. We needed to do total mesorectal thing. Then the Swedish rectal cancer trial showed that radiotherapy was beneficial. Then came the Dutch colorectal group, which also showed that radiotherapy plus surgery was also beneficial. After which we got the German colorectal study, which showed that pre-operative chemo radiotherapy was better than post-operative chemo radiation. And then the Stockholm trial came, which compared short and long course chemoradiation and showed that if they delayed surgery, then it took a long time for response to happen. So by delaying surgery, we got a better PATCR rate. Okay, and then came in the Rapido or the TNT trial. Rapido is also called the TNT trial, and then last is the Prodigy trial. In the Rapido trial, it was considering either short course chemoradiation or long course radiation followed by chemo and then totomesorectal excision had a better rate of sphincter preservation as compared to you know doing the adjuvant chemo here. So here, well, short course and long course chemoradiation, you'll have two considerations. How quickly do you need to go in for surgery? If it's causing bowel obstruction and very disgusting bleeding and a lot of morbidity, then sometimes you can't do the entire long course, which is about 3 months, long course radiation. So you would go for short course radiation. To understand short course and long course, think of an apple. Think of an apple and think of some moldy spots in the apple. Now you want to do a margin resection around it and you want a CRM, a circumferential resection margin. So if you can get a successful circumferential resection margin of the rectum with the total mesorectum, then you can do a short course chemoradiation. But if you can't, you're unable to, get a positive CRM, then it's recommended to go in for long course chemoradiation, which is, a long duration thing. Surgery 6 weeks post chemoradiation. By waiting in, you get a better response. Okay. Now the thing is that The Prodigy 23 showed that a strong triplet induction followed by chemoradiation, followed by waiting, or look at the PAT-CR rate. If you have a high PAT-CR rate, then you don't need to operate. You can just wait and watch as per the opera trial. So, with all these considerations, rectum cancer, uh, you have to choose the type of surgery. You have to choose the duration of radiation, and you have to choose the type of chemotherapy, and you have to manage this patient based on fitness and response. Okay, so to recap the guidelines, up to 5 centimeters from the anal verge, low rectal, mid rectal is 5 to 10, 10 to 15 is high rectal. See the sphincter preservation option, T1 submucosa muscularis is T and M staging. Okay, then you look at histopathology, then we come to the management of localized. So if it is suitable for local excision and if the mesorectal fascia is clear, then you can do a T1 based management. But in intermediate, more locally advanced, where T3AB, very low mesorectal fascia is involved, you can either do short course preoperative radiotherapy in these intermediate risk patients. In greater than T3B and this high risk EMB patients, you should try and do a long course chemoradiation, especially when there is a threatened resection margin. Then we're talking about going in for a long course chemoradiation. Okay, and then look at the post neoadjuvant treatment response rate, PAT-CR rate. So if you look here in a very early disease, you can do local RT or local surgery, and you can do TEM, transanal microsurgery, and you can give perioperative chemoradiation if you have adverse histology, and you can do total mesothelioma in a very early disease. In early disease, where a lot of the patients come, you will do, you can do CTRT, okay, and you can also do a microsurgery, and then you can do an MRI, and you need to do total mesorectal invasion, even though it's a little morbid, but it has to be done. In intermediate disease, you have to do total mesorectal excision. In the high locally advanced stage, see if CRM is threatened or not, then you can choose a short course or a long course, and then you can do the follow-up. In very high risk patients, in the advanced or the ugly, so what these people do is they call it very early, intermediate, bad, and very ugly. So good, bad, and ugly, you know. So like they've called it that, and in the bad group, you can do a wait and watch. Okay, but um, in the intermediate group, you can do wait and watch as well. But here in the advanced and like very aggressive, where the mesorectal fascia is involved and stuff, you should try and do the long course chemoradiation, and then try to give the delay in surgery and look for all these other factors and then manage it. And based on local recurrence, you can either go for, if there's a local recurrence, try for curative options such as chemo, radiation, re-radiation, or surgery based on MDT. Metastatic disease, look like treated like colorectal, where you look at RAS, RAF, VRAF, EGFR, you go for the chemo therapy and radiation for palliative thing. So here is the management of local regional disease. And basically, MDT, look at the CRM, and then that's when you choose long course chemoradiation. Long term implications, You would follow up your patients post-operatively and see if it was high risk, then you would be going for the cardiology, model where you will give adjuvant Folfox. There's a lot of information here. I may not be doing justice in a short crash recap, but should give you some idea. Anything else we'll cover later. Thank you.